Good evening, all. Welcome to our IC on Decoding Pediatric Eyelid Swellings. Two speakers won't be able to join us because of the OPL. So we are starting with Dr. Abarna KS on single out simple swellings first. She is a consultant oculoplastic surgeon at Chaitanya Eye Hospital, Trivandrum. Over to you.
Good evening. Pediatric lid swellings are something that we see very frequently in our clinical practice. Most of them are simple and benign, but sometimes it can present very dramatically and it can be a part of vision threatening or even life threatening condition also. So let's discuss how to single out simple lid swellings. Here we have two kits. First one with a right eye upper lid and lower lid swelling with a history of itching also. And second child with a similar lid swelling. Uh, it is associated with mild tenderness and the history is typically the swelling noticed after waking up in the morning. In the first case, we can see there is some amount of chemosis laterally, and in the second case, there is localized tenderness, induration, and a central bite mark. So, first one is a typical acute allergic edema, and second one is insect bite. Allergic lid edema can be life-threatening also, as an angioedema, which includes lips, face, and can involve the airway also. Contact dermatitis is a delayed onset hypersensitivity reaction that is characterized by lid swelling with a scaling of skin that usually improves after the avoidance of the allergen. Blepharochalasis is characterized by episodic inflammation with a non-pitting edema of the lids. Usually it is bilateral and it is followed by a quiescent stage with a cigarette paper like thin skin. And a painless lid edema can be a part of systemic causes also, as in nephrotic syndrome, that the swelling which is more during the morning and it improves in the later part of the day, and it can be associated with swelling in the other parts of the body like body and face. At another common presentation, some erythematous swelling, and you can see some pustular lesions also. And on stretching the skin, you can see the typical kissing lesions, that is mirror image type of lesions, that is typical of this blister beetle dermatitis caused by Pedrus beetles. If there is painful edema with the lesions having sharp raised edges, think about erysipelas, that is a bacterial infection. And one more cause of painful lid edema. This child presented with upper lid edema. And on close examination, you can see there is erythema laterally and the tenderness at the lid margin. And it is a case of hordeolum with an evolving preseptal cellulitis. Here we have two kids with a erythematous painful lid swelling, and first one is close to the margin, that is a hordeolum, and second one is away from the margin, that is a furunculosis. These two kids with a medial candle swelling, and the first one had a history of previous watering and discharge, and droplets was also positive. It is acute dacryocystitis with a cellulitis picture, and second one is a more superficial infection, that is again furunculosis. Lid abscess is a localized collection of pus within the lid tissue which needs incision and drainage and systemic antibiotics. And here we have to rule out posterior segment, posterior involvement as we have to check for vision, eye movements and proptosis. Preseptal cellulitis is also a common cause of painful lid swelling. It is due to the inflammation of tissues anterior to the orbital septum. And whenever there is red flag signs like proptosis, diminution of extraocular movements, diminution of vision, decreased extraocular movements, RAPD, or systemic features like high grade fever or malaise, we have to admit the patient and start on IV antibiotics. And the spectrum can even include subperiosteal abscess, orbital abscess, and cavernous sinus thrombosis, which needs emergent management. Dirophalariasis is not a rare disease nowadays. It can have a variety of presentations. It is a great mimicker. It can present as on and off lid swelling, diffuse lid swelling due to an actively migrating worm, or it can have a nodular presentation, as in the second picture, due to the confinement of the worm to the subcutaneous tissues with a surrounding granulomatous cover. Molluscum contagiosum lesions are whitish lesions, usually present multiple lesions with the central implications, and it can be associated with follicular conjunctivitis also. And particularly the molluscum contagiosum, molluscum at the lid margins may not be associated with this central implications. And one more, multiple whitish lesions, that is smilia. It is due to the occlusion of pilosebaceous units. It is also seen as multiple round raised whitish lesions, but it is more well circumscribed, and it is usually smaller. This pinkish swelling with the multiple whitish dots on the surface and with a history of taking bath in the common pond is rhinosporidiosis. One more pinkish lesion with a history of repeated bleeding, that is pyogenic granuloma, which is a common acquired vascular lesion, and another pinkish lesion, that is burst chalazion. Here a long-standing chalazion that burst into the palpebral conjunctiva, releasing its contents. Dacryoadenitis is an inflammation of the lacrimal gland. So it presents with a lid swelling in the superior lateral aspect and with an S-shaped deformity of the lid. It can be unilateral or bilateral, and it can be due to various causes like infections, inflammation, autoimmune causes like that. Another child with a superior lateral orbital mass. It is a dermoid cyst. It is a congenital hematoma which presents at the site of suture lines. So it can have an external angular or an internal angular presentation. This child, 14-year-old child who presented with a superior lateral orbital mass, on imaging, there was a well-defined isodense lesion which is suggestive of a benign adenoma of the lacrimal gland. So we did a lateral orbitotomy and sent for biopsy, and it showed typical cystis appearance. It was an adenoid cystic carcinoma, which is very, very rare in pediatric population, but it can have a bimodal presentation, can present in the pediatric age group also. So what I wanted to stress is pediatric painless proptosis and orbital mass is not always benign. Capillary hemangioma is a vascular lesion of infancy that can present as superficial strawberry nevus lesions, or deeper lesions can appear as bluish purple lesions. Here we have to rule out associated systemic conditions like Kasabag-Murray syndrome, Maffucci syndrome, Faces syndrome, etc. AV malformations or venolymphatic malformations, that is other vascular lesions of the orbit, can also present as a lid swelling with a bluish tinge. This child who presented with a history of trauma, and you can see a huge hematoma in the upper lid, and eye was otherwise quiet. One more child who presented with a history of trauma, but you can see some proptosis there and a palpable mass was there, and that turned out to be rhabdomyosarcoma. So always look beyond history because clue may be hidden. This febrile active child who presented with a lid swelling, and I noticed that there is some amount of limitation of elevation, and I sent for an imaging, and that turned out to be orbital lobe intraparenchymal abscess, and child was immediately referred to neurosurgeon. So if you feel that there is something abnormal, don't hesitate, send for imaging always. This child who was treated as chalazion and even posted for INC elsewhere and came for a second opinion. And on eversion, this foreign body material, that is a back portion of a pen, this material came out. So always make a habit of everting and seeing the lid swellings. One more interesting case, this child with a history of lid swelling, and you can see some congestion, superior bulbar congestion, and her mother bought this bottle full of different varieties of insects, and she revealed a history that her child has a habit of keeping all this insect into the superior fornix and to induce conjunctivitis, and the motive is just to escape from exams. So, stay alert. Pediatric presentations can be dramatic and even deceptive. So, lid swelling is an important sign as well as symptom. It may be benign, but it can be vision threatening or life threatening also. So, the key is to single out simple swellings and make sure that we are dealing with a harmless swelling. Thank you.
We'll keep the discussion to the end. Next on stage, we have Dr. Saumya. She's a consultant plastic oculoplasty surgeon at Calicut, and she's a freelancing oculoplasty surgeon also. She'll be dealing with the hidden threat of orbit.
So we have heard common swellings. Now I will be reading the hidden threat behind these cute eyes. So this is a 1-year-old child came with a history of swelling in the right lower lid with since past 4 or 5 months with a rapid progression in the last 20 days. On palpation, there was an ill-defined firm to hard swelling in the infraorbital area. You can see the lower lid is very tense. So for this patient, CT was done and it was found to be homogeneous, round to ovoid mass, which were isodense to the muscle. So incision biopsy with the inferior fornical and external approach was done. The mass was identified grossly. It was fibrous to fleshy in appearance, pinkish in color, and found to be infiltrating to the surrounding structures. And the HPE showed, you can see the eosinophilic background and plenty of tumor cells with intermediate to large size, oval to round in shape. And this was diagnostic of malignant round cell tumor. So the immunohistochemistry was done, which showed positive for desmin, MSA, MyoD1, and negative for CK, CD45, and synaptophysin. So it was suggestive of embryonal rhabdomyosarcoma. The PET-CT was done, and it was the tumor was confined to the right orbit, inframedial aspect in the extracornal space. So according to the AGCC staging, it was T2, N0, M0. The patient was referred to the pediatric oncologist. So rhabdomyosarcoma is the most common primary orbital malignancy in children and also the most common childhood soft tissue sarcoma. It usually appears in the age of 7 to 8 years with a male preponderance, and in the eye, orbit is affected in most common cases. And according in the morphological classification in the WHO, which is amended in 2020, is classified into embryonal, alveolar, spindle cell, and pleomorphic. So for the treatment, complete or near complete surgical excision is important without damaging any vital structures, and which will help in the confirmation of the diagnosis and histopathological typing. Then we have to we have to seek the help of a pediatric oncologist for the further management. So according to the excision, we can the staging system of the intergroup rhabdomyosarcoma study showed that it's divided into group 1 to 4. In group 1, the disease is localized and completely resected. Group 2, this is completely resected, but there is a regional spread. Group 3 is incomplete resection, and group 4 is distant metastasis. So for group 1, 2, 3, into group 1, we can give chemotherapy alone, and group 2, 3, 4 may require radiotherapy, additional radiotherapy, depending on the extent of the disease. So usual chemotherapeutic agents are vincristine and actinomycin, and newer agents like ifosfamide and etoposide are also beneficial. So radiation, as I told, is for group 2, 3, and 4, and in the range of 4,000 to 5,000 centigrade in 4 to 5 weeks. And if there is intracranial spread, we have to definitely give radiation. So also in these kind of patients, we have to keep the differentials of rapidly progressing masses like neuroblastoma, chloroma in our mind, and also some inflammatory pathologies. As this follow-up is very much important, we have to see in 3-4 months initially for the first year, and 4 to 5 months in the next several years. We have to do a comprehensive ocular examination, and if in doubt, we have to do an imaging. So in the case, this is a case 2, where a 6-year-old girl presented with a diffuse progressive soft tissue mass in the soft tissue pulsated mass in the medial aspect of the right upper eyelid since birth, causing ptosis. The surface of the lesion, you can see there is dilated blood vessel, and there was a bruit head-on auscultation. The patient had a amblyopic vision, decreased vision in right eye, rounding finger 1 meter. So in the CT was taken, a diffuse preseptal isodense mass is present in the supranasal aspect of the right orbit, and on contrast, there is it enhances brightly during the arterial phase of the contrast. So the diagnosis of a arteriovenous malformation is done. So, according to the International Society on Study of Vascular Anomalies, all the vascular anomalies are divided into vascular tumors like hemangioma and vascular malformation. So, this arteriovenous malformation comes in the simple vascular malformation type 4. This is a direct connection between the arteries and veins bypassing the capillary blood. And these are high flow vascular lesions. So CT and MRI will help in diagnosis, but digital subtraction cerebral angiography remains the gold standard in mapping the needles and finding out which are the feeder arteries and what is the venous drainage, and also essentially for gaining the selective embolization and assessing the therapeutic efficiency. So treatment is multidisciplinary. Endovascular embolization followed by surgical excision has the highest success rate and lower recurrence rate. So this is the DSA of the patient showing the needles is fed by the branches of both external and internal carotid artery and drained by the superior ophthalmic vein. For this patient, they have used a 16% N-butyl to cyanoacrylate glue to selectively, they have done the super selective cannulation to the right ophthalmic artery and also direct intralesional glue injection. So after 72 hours, surgical excision was done. With this embolization helped in complete surgical excision without much bleeding. So there are high recurrence rate and so follow-up is essential. In the case 3, you can see the patient had a fullness in the left supramedial aspect and subconjugal hemorrhage and dilated vessels. Valsalva was negative for this patient. Patient was underwent MRI showing ill-defined mass extracondyly with a cystic and solid component with minimal contrast enhancement. So the diagnosis of venous lymphatic malformation was made. This is the most commonly occurring in the head and neck region of the pediatric population. And there can be what is the threat here is the acute vision loss can occur due to intralesional hemorrhage, especially during a URTA, and it can cause optic nerve compression. And also there are reports of the lesion extending into the cavernous sinus and causing bleeding there and sudden vision loss. So according to the ISSVA classification, it is coming under the combined vascular malformations. And according to the site, we can classify it as superficial, deep, combined, or complex. The complex when it is extending beyond the eye. It can be, depending on the size of the cyst, we can divide it into microcystic lesion, macrocystic lesion, and mixed. So, in the venolymphatic malformation, there won't be any obvious plane between the lesion and the surrounding normal orbital structures. So, complete surgical excision is very hazardous. So, if we are doing incomplete excision, it can go for recurrence. So, there is the scope of fluorescence. So the primary treatment for VLM is now intralesional injection of bleomycin, which is an anti-neoplastic antibiotic, which the mechanism is apoptosis and inhibition of DNA, which leads to the fibrosis and induced inflammation. So the recommended dose is 0.02 to 0.5 international unit per kilogram body weight. We have to reconstitute it with sterile water, in which equal amount of 2% echinocane is also added in 1:1 ratio. And during the procedure, we will be putting a cannula or a needle into the cystic part of the lesion, either direct or with USG guidance. And we have to aspirate the fluid and see if we are in the cyst. So after the aspiration, we have to inject the bleomycin, not more than 20% of the aspirate. So the bleomycin injection will give a very better result in VLM. This is a fourth case. You can see a fullness in the lateral aspect of this 6-year-old boy. So we fixed non-tender mass, subcutaneous mass adherent to the bony plane. The CT showed you can see a lesion in the extracorneal space and also extending into the temporal fossa through a defect in the frontozygomatic suture. So the diagnosis of a dumbbell-shaped dermoid is obtained. So there are two lobes of the cyst which is connected through a bony canal through an opening in the, especially normally during a suture line. So it can either extend into the temporal fossa or middle cerebral fossa or frontal sinus. CT is the diagnostic of choice. For the excision, we know that in all cases of dermoids, we have to excise it completely without any rupture. If there is any rupture or any residue, it will cause inflammation. So for that, we have to we require a temporary removal or modification of the adjacent bone. Usually, we can widen the bony part, which will help in complete excision, preventing rupture and access and visualization of the internal cyst. And also there will be some bony thinning that can also be managed. So in all cases of pediatric cases, we should have a high index of suspicion to find out all these hidden threats, and early diagnosis will give a better prognosis. Thank you. And welcome all to the OPI 2026, which is happening in Kochi. Thank you all.
Thank you, Dr. Soumya. Now we have Dr. Marian Poli, madam. She's a senior consultant oculoplastic surgeon at Giridhar Eye Institute. She'll be sharing some rare case scenarios.
Thank you. Good afternoon. At the outset, let me thank Soumya and Shebin for giving me this opportunity. So we have listened to both Dr. Soumya and Dr. Aparna regarding some common things and the common threads. So I'm just presenting some rare scenarios, but they present like a common thing, but turned out to be a little rare thing. So my first case is an 8-year-old child presented to us with occasional diplopia following a vague trauma. So this was the clinical picture. You can see the globe is displaced down and there is a gross fullness in the superior quadrant of the left eye. Now look at the scan. The scan, we can see a well-defined mass in the superior quadrant. The radiologist reported it as hemangioma, and the ophthalmologist or the concerned doctor treated with oral propranolol. So now the question comes, is it hemangioma? Should I continue the oral propranolol? Let us see one more case. The histopathology turned out to be rhabdomyosarcoma. I'll speak later. So this is another child, 9 years. Again, history of vague trauma. Came with a grandmother because parents are abroad, with a swelling in the left eye of 2 weeks duration. And the CT scan showed a mass in the superior quadrant. You can see it is actually involving the superior rectus, but rest all orbit is normal. Here also the radiologist reported as hemangioma, and MRI was also done since we had a confusion. So MRI also reported as hemangioma. But see, there are two things in this. Hemangioma usually occurs in histopathology was rhabdomyosarcoma. Now we'll see how a hemangioma looks like. A hemangioma usually starts at 3 weeks of life, like within 1 month, and it gradually progresses and reaches by 1 year of age, it reaches its maximum size, and then it gradually starts involuting. So here also you can see one hemangioma. Look at the color of the lesion. Now look at the other two kids. So this is our child 1 and this is our child 2. So how to differentiate? History is very, very important in localizing the pediatric lesions and imaging, of course. So the first picture is a picture of a MRI of a hemangioma, where you can see some flow voids, like the dark spaces inside the hyperintense lesions. Whereas the second MRI is a case of rhabdomyosarcoma or any other solid mass lesion where it is uniformly solid. So this is one way history and clinical findings and radiology will help you. You cannot blame the radiologist because we are the one who are seeing the patient and we have got a clinical diagnosis. So now coming to another patient. He is an 11-year-old boy presented with a recurrent swelling in the left eye. So you can see there is a minimal fullness in the left eye. Already he was treated by oral antibiotics and NSAIDs before presenting to us. So now look at the scan. So he was advised CT scan, and you can see some bone erosions in the temporal wall, lateral wall, and you can see an ill-defined mass in the temporal near the lacrimal gland area. And in this you can see some bone erosion is clearly seen in this picture. So from Dr. Same, we saw dumbbell dermoid. So one possibility can be a dumbbell dermoid, but usually dumbbell dermoids rarely presents with inflammation. So I also thought could be an initial double dermoid. So however, under frozen section, we did biopsy and the biopsy showed inflammatory cells. So we excised as well as we gave intralesional triamcinolone and the child did well on follow-up. So this inflammatory lesions initially presents with cellulitis. Initially always we treat with oral antibiotics. However, imaging will give a clue to the diagnosis. So imaging is important. So there is always a question of debate. MRI versus CT. I prefer CT scan, 2 reasons. One, to get an MRI in a child, you need sedation. For the sedation, you get anesthesia, open, a lot of formalities. CT scan is very quick and you get the result in under 30 minutes. But there are few lesions which requires MRI. So the child did well with the treatment and this is the post-operative picture and follow-up at the last follow-up. So this is another patient, 8-year-old child. From the clinical diagnosis, this is a case of orbital cellulitis or preseptal cellulitis. Already received oral antibiotics before presenting to us. So as a routine, orbital cellulitis always admit and treat. So the child was admitted around 10 a.m. So this was the presentation, at 10 a.m. presentation. Left lid there was mild swelling, but we were also wondering why the swelling in the left eye. So initially we thought some dependent edema. But after 5 to 7 hours, you can see the swelling in the left eye is increasing. Right eye also the erythema has increased. Meanwhile, the duty doctor also told there are some rashes in the hand. So then really we got confused. This is not a normal cellulitis, this is some atypical cellulitis. So we did an immune workup because already the child had routine blood, etc. when they came to us. So we did immune workup and the anti-nuclear antibody was positive. The child was referred to pediatric rheumatologist and the baby had end-stage renal disease and she was given dialysis in the same week itself. So admitting and monitoring an orbital atypical cellulitis is always very, very important, especially in diagnosing some rare instances like this. Periocular parasitic diarrhea we have already seen, but the presentations can vary in like different ways. And especially in pediatric, it's literally very difficult to diagnose and sometimes to get a diagnosis as well as to treat also. Because to convince the parents, we have to be like, they will ask you whether the child will get parasite. So this is a child who presented with a recurrent lid edema and you can see a nodule in the temporal part. And here, no need to go for any MRI or CT because it is confined to the lid. Rest of the eye is perfectly normal. A simple ultrasound of 5 minutes will give you the diagnosis as parasitic cyst. And treatment is excision of the mass. Second thing, this is a 1-year-old child, again presented with the initially inflammation, then presented with a nodule. So this also turned out to be a parasite and here also parasite. So how to differentiate between an infective cellulitis and a periocular parasitosis, because parasite is very common now. One history, they always give a fleeting edema. Yesterday it was okay, today it is more. Cellulitis usually it increases. Most of the time without treatment it increases. Parasite usually it is like ups and downs, fleeting edema. And second thing, in cellulitis usually kids are little toxic. They'll have fever, not able to take food properly, etc. But here the child will be like perfectly normal except for the mild swelling and ultrasound will give the clue. Whereas in cellulitis you have to go for CT or MRI to assess associated sinusitis, etc. So differentiating an infective cellulitis versus a parasite is very, very important in the management. Now coming to another patient, she is a 7-year-old presented with a swelling since 3 weeks. So you can see there is a definite swelling in the left eye. So we did a CT scan. It showed inflammation in the temporal quadrant involving the lacrimal gland. And the most important thing is that mass is indenting the globe. So in this case, you cannot, any mass that is indenting the globe is not a regular inflammation. So we did a biopsy with the debulking and showed it as granulomatous inflammation. Then child was referred to a rheumatologist and started on steroids. So here also imaging gives the clue. Now coming to ligneous conjunctivitis, this is looks like a vernal, but this is very difficult condition to treat. We use cyclosporin drops, then excision, amniotic membrane, still it will recur. So ligneous conjunctivitis also it's a little rare, but it's very difficult to treat also, but we have to diagnose. So coming to the last case, the 13-year-old girl presented with a recurrent lid mass since 3 years. Because before the child presenting to us, she had already undergone 2 INCs. So that is why they presented to us. Now look at the character of this mass. So if you see there is an area of loss of flashes. The lid margin is not very well defined. You cannot see the meibomian gland orifice, but the tarsal area is perfectly normal. So initially, I have not seen such case in a pediatric. So I was also like clinically, I didn't have any diagnosis. But one thing I know, it is not a malignant tumor. So whatever it is, under frozen section guidance, we took the child, and the frozen section itself showed it was a benign tumor, and the final biopsy report was granular cell tumor. That's a tumor that arises from the neural sheath, and complete excision was done in the form of wedge resection. So this is also, so rare findings will give a rare diagnosis. So that is one thing that we have to keep in mind. So to conclude, history is very important, but in pediatric age group, it can be very misleading also. So you have to correlate with the clinical findings to reach a diagnosis. Imaging depending on the scenario, biopsy in relevant cases, and excellent outcome in most of the cases. Thank you so much.
Thank you, Dr. Marian, for the elaborative talk. It's my privilege to welcome my batchmate, Dr. Yasser Safar, for his talk on approach to lid swellings. He is a consultant oculoplastic surgeon at Agarwala Hospital, Trivandrum.
Good evening. Thanks to KSOS and Dr. Soumya for this opportunity. Now I will be dealing with the pediatric eyelid swellings, how to proceed. Like when you get a pediatric eyelid swelling, what are the things that you have to look for? So we have gone through multiple sessions, like the simple one to the aggressive ones and to the rare and through the rare ones. So how to manage a case when you get a case? So as in Dr. Abarna has mentioned, you can see chalazions, you can see granulomas, you can see dermoids, you can see allergic reactions, you can see simple small neosis, or you can see a capillary hemangioma. Sometimes you can see allergic conjunctivitis, like VKC kind of picture, or even a parasite or a tick. And sometimes they may present acutely with red swollen eye like this, with orbital cellitis, dacryocystitis, etc. And sometimes you can have some hidden threats like mostly parasitic infestations, AV malformations on your thyroid eye diseases, or like round cell tumors, which are pretty common in pediatric age group. So mostly when we come to the cause, it can be mostly allergy, especially if the swelling is not intense, and if the kid or the parent gives a history of any allergen exposure, or sometimes can be an insect bite, or sometimes maybe medicine, or sometimes maybe something some intake. But mostly the allergic edema will be bilateral, and the other next cause could be inflammation. The allergy causes will be usually acute in onset, and the child won't be that toxic. Coming to the inflammatory markers, there will be some kind of inflammatory signs. There will be erythema, induration, and in case of infections, the presentation is mostly in pediatric age group. It's acute to subacute, and the vascular lesions mostly will be from birth, and or there will be some signs at birth, and which as the child grows, the presentation will become more evident. Neoplastic cases, as discussed earlier, is not uncommon in pediatric age groups. So how to proceed it? So as in a history of present illness, we have to go through where is the location of the tumor, or where is the swelling located, and the characteristics or the quality of the tumor. We have to describe any adjacent lesions or any surrounding lesions, any hair fall, loss of hair follicles, any induration, erythema, such kind of things. this timing, onset, duration, and timing is also important. When was when the lesion has begun, whether it was there from the birth, or it has begun 2 weeks or 3 weeks from the birth, or has it gone from at an acute onset or something like that. And you should look into the any aggravating or relieving factors, or look into the other symptoms like fever, malaise, nausea, such kind of things as also. So basically you should look into the character of the kid also, or when they present to us as we complete history, you should look into the general examination also. Look if the child is toxic, look if the child is febrile, if the child is pale, and look for the chest and abdomen also, because pediatric neuroendocrine tumors or round cell tumors are not uncommon. And torsilate examination is becoming uncommon in ophthalmic practice, but make sure that you do a torsilate examination in pediatric eye group, because many things that you can miss in a slit line examination could be found in torsilate examination. And make sure that you do an inverted eyelid examination in all cases in pediatric lid tumors, and use a bud or a retractor to make sure that you see the tarsal plate, and look for the look for any postal variation when the kid presents you, or like do a Valsalva manner if needed, and go for the slit lamp examination after you finishing these basic examination. And imaging is needed whenever you find that the swelling is extending beyond the fornices, or if it's extending beyond the tarsus, or if it's extending into the orbital diseases. So why you want to look into the general examination? Look, see the first picture is of a kid who presented with a subconjunctival hemorrhage, and the parents were not giving any history of any trauma. 2 weeks later, the initial surgeon, the initial ophthalmologist thought it's to be some traumatic. The kid is not giving a proper history, but 2 weeks later, the kid presented with hypertropia, and on imaging, there was a mass, and eventually turned out to be neuroblastoma. And and that's the importance of a kid presenting with such kind of subconjunctival hemorrhage in ECMS also. Make sure that you get a proper history. Make sure that you see the kid in total and try to palpate for any mass lesions. And look if the kid is febrile, if the kid has any malaise, and look for the history of upper respiratory tract infections, like which can lead to orbital cellulitis or orbital cellulitis. And look for palpate for the chest and abdomen if needed, because as said earlier, to rule out any any nephroblastoma or anything like that. Proptosis, thyroid is not uncommon in thyroid disease, and orbital inflammatory disorders are not uncommon in kids. And any case that present with squinting, it's better to be evaluated properly. Torsilate examination to describe if the lesions are generalized or localized. Touch and feel the lesion. See if it's tense, if it's non-tense, if there is erythema, if there is induration. Make sure that you look for the extraocular motility in all these kind of patients. Make sure that you invert the lid and see what's in there, and look for any postal variations, and ask the patient to do a Valsalva manner, because most of the vascular lesions can prop up with a proper Valsalva manner or a bend down posture. And as not the least, visual acuity, color vision, and visual fields if the child is cooperative. And make sure that you see through the lids and adnexa, cornea, and the posterior findings also, because sometimes a posteriorly located lesion can present with choroidal folds, and you may have some intraocular lesions also that you can corroborate with the present findings. Imaging, as described, the preceptal lesions are mostly, if it's a cystic one, could be easily taken up by a ultrasound USG scan. Whether to take a CT or MRI in doubtful cases depends on the availability, and I do suggest to go for an MRI if the patients are affordable and the child can cooperate for the investigation, because of the high dose of radiation exposure that the kid may have to go through while going for a CT. Vascular lesions mostly will have to go for a contrast imaging, or will have to go for a DSA imaging to find the cause. And when you need to refer to a colleague or when you need to refer to a oculoplastic surgeon, sometimes you will need to refer to a patient to a pediatrics where we can admit the patient and give the IV antibiotics. Look, if the kid is febrile, if he has malaise, if there is severe tenderness, if there is prominence of globe, if there is any limitation of eye movements or respiratory tract signs, it can be orbital cellitis which might need IV antibiotics or parenteral antibiotics. So such cases are better to be referred on an emergent basis. And the management of lid tumors, it's a wide variety and it's a wide spectra. So some cases can be observed, some cases will respond well to medical management, and some cases will need a mild and minor surgical therapy, or some cases will need a major surgical interventions. And describe some of the rare diseases will need chemo or radiation depending upon what the cause is, or sometimes steroids also. And to conclude, history plays a major role on as to describe the course of events for the disease, and clinical examination and imaging studies help you to describe on how to deal with this, and what lesion you are dealing with also. Thank you.
Thank you, Dr. Yasser. As two of our speakers are held up at OPL session, we are open for discussions.
I would like to ask, how do you go about a case of VLM, veno-lymphatic malformation, if it's in a child? Madam, would you like to answer?
VLM, you have to get an opinion. Once you have to diagnose, then interventional radiologist should help you with either embolization, depending on the extent, or glue you can inject. We are asking for VLM. Okay. Depending on the presentation. For example, if the child presents, we have seen patients at 6 months with VLM. It's very difficult to diagnose at 6 months. Can manage conservatively if there is no compression. Nothing will happen. But if you intervene early, I think it will end up in complications. That is my personal experience. If the child presents with compressive neuropathy, start steroids, most of the time it will settle down. Okay. There are a group of patients, even if you start steroids, IOP is going high, too much of astigmatism because compression on the globe. In that case, can intervene with bleomycin.
So during acute bleed, bleomycin, will it work, ma'am?
Acute bleed, very tricky. It will actually cause rebleed. So acute bleed, I always manage conservatively.
Also the oral propranolol for capillary hemangioma, how long we have to give?
Yeah, so oral propranolol, actually we have to modify the natural history by oral propranolol. So start 0.2 to 2 milligram. Actually, I never start. It is referred to the neonatologist. Then continue till 1 year of age. And I don't stop abruptly. It is gradual tapering of propranolol. I have seen only 1 or 2 cases getting recurrences. Then I will restart propranolol and continue for another 6 months. So maximum up to 1.5 years.
What is your experience with the topical timolol for capillary
I
hemangioma?
always give all the patients topical timolol. Timolet OD mixed with lacril gel.
How is the response, ma'am?
Superficial lesions will respond, but deep lesions need oral propranolol. Initially, actually, there was some indications to treat. Now, actually, for all the thing, if the parents are willing, I do start. What I have seen is if the lid will become loose if you don't treat. So later, they will have some cosmetic blemishes, asymmetry in the lid crease, etc. Like after 12 years and all. So what I thought is if you start early, that laxity of the lid will be less. So that you'll get a perfect symmetry when they reach teenage.
Ma'am, I have one more question. In case of pediatric dirofilarosis, if they are not willing for excision, how will you proceed? Is there any role for antiparasitic medications?
Less than 1 year, actually, ivermectin is not recommended. So I start steroids only, oral steroids, and most of the time it will end up in excision. Just to reduce acute inflammation, oral steroids. Then, even when I prescribed ivermectin in one child, the mother asked, Less than 1 year, we will not give antihelminthic medications. Okay. So people are very educated compared to us.
Acroadinitis, ma'am. Many cases will come with acute acroadinitis, especially in the pediatric age group in around 10 to 12 years. So how do you deal with it?
Acroadinitis mostly post-viral. Yeah. So you have to do immune workup and start steroids. I always take an opinion from pediatrician also. Basic workup, anti-nuclear, all the thing, ANCA, INA, everything, TB, quantiferon TB gold, IgG4. That regular panel, ANA, ANCA, angiotensin converting enzyme, IgG4, QTB, TB.
I mean, how young this bleomycin can be used? If the child, the neonate, it's like in the first 1 month or so. What is the age limit that?
About 6 months. About 6 months. But these are a little rare. Maximum I'll manage with the steroids if the vision is not threatened.
We have had one such child,
yes.
it was 3 months old.
Children with MGD not responding to topical medications, how will you proceed, ma'am? Multiple chalazion and all.
Very difficult. What I do is the pediatric, if they are agreed to lie down under microscope, you can actually manually squeeze the eyelid to express the secretions from the meibomian gland. So now if we planned for a prospective study with LipiView to assess the assess the morphology of the meibomian gland, why they're getting recurrent chalazion, and the role of meibothermoflow. It's little less costlier compared to LipiFlow, thought of. So now what I'm doing is manually express the eyelid between the two kuchi, and they will improve. Lot of patients coming like that, recurrent chalazion, no refractive error. Then all conservative measures, hot fermentation, lid massage, etc.
Can we start doxy, madam, at what age?
No, less than 14 years, no. It causes problem with the cartilage growth. We can start oral azithromycin. Actually, I start azithromycin once in a month for 3 consecutive months.
Thank you, ma'am.
Ma'am, what is your experience with the tick granuloma?
Of
Tick granuloma.
chalazion.
No, tick granuloma kind of.
Ticks.
Yeah, what do you do?
You have to remove the tick and give
No,
steroids.
just the granuloma. How the usual present tick has been already removed. The patient comes with a
Topical
swelling.
steroids, it will improve. It will take a long time.
Yeah.
3 months.
It is presenting like recurrent.
But
Yeah, come and
actually, you have to do an ultrasound to see any residual of the tick inside. If your tick is completely removed, then you can manage with the topical steroids. I have seen few cases, only 3 cases only. I have seen one patient was literally shouted at me because it was fleeting. But eventually, at the end of 3 months, he improved. 3 months, I gave chlorocol. Topical, lotipretnol, chlorocol H, same medicine you cannot give every time.
It's on the anterior side. If it's on the anterior side.
Yeah, lid, no?
Yes.
Oral steroids we can give. I don't know any role for intralesional steroids.
I had actually once tried because it was coming again and again.
Intralesional
Oral
steroids
steroids was given. It was topical that time, but then again it recurred. So I had to give the topical steroids.
Intralesional
Steroids. It recurred. I mean, for some time it was all okay, but then again recurred after some time.
But did you do an ultrasound to see any residual?
No, not yet.
In that child, actually, I only removed the tick. When it was getting recurrent episode, I did an ultrasound to see anything, but there was nothing, only inflammation.
Ma'am, in the blepharochalasis, how you are managing?
Diagnosed blepharochalasis, recurrent lid edema, ruled out everything, did imaging, did all the investigations, can't find any reason. So diagnosis is blepharochalasis. So now we tell them stress can aggravate any kind of stress, exam, decreased sleep, a lot of things. Then I ask them to put chloroquine H whenever the edema starts for 2 weeks. Then we have to reassure them. Then nothing more. Actually, Diamox can be given, but pediatrics I have not given. Adults I routinely give Diamox. Once daily for 1 week. 1 week. So they know when the edema will come. First day, let them start. But pediatric, I have not given, even though the patients which I saw like 10 years before, I am doing blepharoplasty now. So it is like convincing the patient because they will go to all the places. Finally, they will get convinced, no treatment for this. Then they will agree. They will come back to us.
Blepharochalasis, madam, when do you take up the patient for blepharoplasty?
That's very difficult. Actually, the textbook says 6 months. But I have taken up patients after 6 months, but they had recurrence. Again, not doing surgery and doing surgery will be the same. So I personally feel after 30 years of age.
So page and a stable story.
Yes. So that's what I have learned from my experience. Yeah.
That's what we need.
But now I know. Now, even if I do surgery in 20s, you will require a revision surgery by 30s. So they're okay.
We are concluding the session.